Right, okay, so my name's Julian Berryman. I am going to be giving you a presentation today on, or the title of the presentation is We All Have the Right to Be Active, and we're looking at the whole area of health inequalities, and I'll explain, and hopefully what that term actually means will become increasingly clear as we go through the presentation. But it's a huge issue in the society that we're living in, and something that all health and fitness professionals need to be aware of, I would say. Just to introduce myself, yes, Julian Berryman, I'm the Director of Research and Development at Premier Training International, and maybe there's even some of my old students out there listening to this presentation. I hope so. I used to do a lot of teaching, not so much these days. I've been with the organisation for 20 years plus, so yeah, a bit of an old timer. But I have actually been more recently, yes, we continue to deliver our diploma in personal training, but more recently I've been very focused on the whole area of public health and how do we impact on public health, how do we impact on the health and well-being of the nation, and that's a lot to do with what this talk is going to be about today. You will get the opportunity to ask some questions. Like I said, question chat box, put as I talk, if you've got any questions, stick them in there, and at the end of the presentation, which I hope will sort of take about 30-40 minutes, we should have 15 or 20 minutes to go through a few of those questions. I'll try and answer as many of those as I possibly can. If we've got lots, then I'll cherry pick a few. If we don't, I'll try and answer them all. Okay, so we all have the right to be active. Here we go. Hopefully I'll press the right button here. Okay, good. First slide. So the state of the fitness industry. So just to sort of paint a bit of a picture here, total market value is estimated at 3.92 billion. Sounds like a lot, doesn't it? And that is up 1.5% on 2012. Okay, fine. 12.6% of the UK population now members of a private or public health and fitness club. That's up on the previous year again. It was 12.1, so 0.5%. So, you know, what you think of that, that's an interesting figure. I don't know if you were aware of that, but yes, it is growing, and so that's a positive, but it's only 12.6% of the population are actually using gyms or are members of gyms. It doesn't actually tell us how many of those people are regularly using those gyms. So there's a big proportion of the population out there who don't seem to be engaging with a typical health and fitness club. They may be doing other things, but they don't seem to be engaging in that situation. So often the industry talks about growing the pie. So how can we get more people coming into our gyms? And that may be part of what we're presenting on today. There are now 6,000 approximately fitness facilities in the UK, and this is up again on 2012. So all of these things would perhaps indicate that the industry is growing, is a dynamic one. Okay, so, and there we go. It's a dynamic and healthy industry, and we've got some wonderful shots of some wonderfully good-looking people, and we have to maybe think about these images that we're portraying. You know, how would Joe Public, your typical puncher out there, maybe view some of these images and the way we portray ourselves as an industry? Are they particularly accessible, or is the gym really, for some people, almost unobtainable? That the images that we portray maybe put people off. And just for your interest, of all those wonderful muscular people, unfortunately, I have actually included myself in there on the right-hand side as you look, just so you know who the hell is talking to you here. That's not a particularly recent shot, I've got to say, and that is me at my best. So think of that what you may. Okay, so it is a dynamic and healthy industry, or so it seems to be, and we'd like to be part of something like that, I guess. But let's just take a bit of a closer look, shall we, at this industry that we're in. So there is, in actual fact, as I'm sure many of you are aware, an inactivity epidemic. 12.5 million adults classed as physically inactive in England. That's 1 in 4 adults who are failing to achieve 30 minutes of moderate activity per week. So that's pretty worrying. Over the last 50 years, physical activity levels have declined by 20%. And you can attribute whatever reasons you want to that, technology, whatever, in the UK, with predictions of a further 15% drop by 2030. So things aren't improving. By 2030, the average British person will use only 25% more energy than they would have done had they just spent the day in bed. That seems crazy, doesn't it? So we've got to ask ourselves here, yes, okay, we've got an industry that appears to be growing. There is a commercial basis for that industry. There's lots of people making money out of that industry, and you may yourself be making money out of that industry. But if we take a wider look at the society and how active we all are and how healthy we all are we truly, as an industry, having an impact on the health of our nation? And you would sort of think, looking at those sort of stats, and there are many stats like that, that perhaps we need to think about that a little bit, and maybe we're not doing such a great job after all. So risks of inactivity, I mean, we all intrinsically know as people involved in the industry that inactivity is not a great thing, it's not a healthy thing, and is, I think now the World Health Organization ranks it as the fourth highest ranking cause of global mortality, physical inactivity. So inactivity significantly heightens the risk of developing chronic illnesses, any number of chronic illnesses, whereas engaging in physical activity itself offsets many of those conditions, many of those non-communicable diseases as they're often described. So, you know, that could be it could be a cardiovascular problem, it might be cancer risk, it could be any number of chronic conditions, and physical activity in many cases being proved to be beneficial in those cases. Inactivity responsible for 17% of premature deaths in the UK every year. That's quite a high percentage, and shortens the lifespan by 3 to 5 years. We'll expand on that point a little bit more as we go. Inactivity is costing the national economy in England £8.2 billion per year. So if we could get the nation more active, then that would be a positive thing, not only in terms of the health of our nation, but also the economy of our nation. And in a time of financial restraint, of austerity, when the government are cutting back on public services, and we constantly hear about the health service and how that's in trouble, and the funding of the health services in trouble, and is that a sustainable model, then anything we can do to offset costs, national economic costs, has got to be a good thing. More contraindications. So health outcomes such as life expectancy continue to improve in the UK. So we're saying that people are increasingly inactive, there's increasing levels of poor health. We can quote various obesity statistics, and I'll come on to those as we progress, but basically 2/3 of the population are overweight or obese, which is another scary statistic. But health outcomes such as life expectancy continue to improve in the UK. So there's a lot of ill health around, but we are living longer. Average life expectancy has soared to 80 years old, 8 years higher than in the 1970s. So we're living longer than previously, but there seems to be more ill health around. And we wonder, don't we, why the health service is struggling, because people are living longer, but they need care, they are in ill health, and therefore that is very taxing on our National Health Service. What can we as an industry do to help that? What can you do? What can I do? I'm trying to do my bit. Right, a widening gap. So the fact that we are seemingly living longer masks a widening gap between the health outcomes of the wealthiest and the most deprived communities. So, you know, are we all living longer, and how long are we living? Are we all living in good health for longer? So life expectancy. In England, people are living in the poorest area. In England, people living in the poorest areas will die an average of 7 years earlier than those living in the richest areas. 7 years. That's quite a long time to lose. So 7 years less life for those living in the poorest areas. In England, the average difference in disability-free life expectancy between the poorest and the richest is 17 years. So the poorer groups in our community, the more deprived groups in our community, are not only dying earlier, but they're actually living in ill health for longer, which is not a very pleasant situation for them, clearly, but also has a big impact, again, economically, in terms of the care that is required with those people living in poor health. And I just threw that one in because I thought that was quite interesting. Unskilled workers are twice as likely to die from cancer as professionals. So, you know, some fairly startling statistics. Smoking rates are the highest in unskilled workers in the poorest communities, and there may be some link there, clearly. Okay. So, life expectancy lower for the poor in our society, and they're living in ill health for much longer. So we actually have some active inequalities here. Inactivity levels are 10% higher in the most deprived areas in England compared to the least deprived. So, you know, all those statistics about not living as long and living in poor health may well be linked into the fact that those poorer communities are also much more inactive. And 13 of the top 15 most inactive local authorities, and the UK Active, our trade organisation, did an exercise where they looked at all of the local authorities and their activity levels. 13 of the top 15 most inactive local authorities all sit in the most deprived or the more deprived socio-economic quintile. So there's a link here with inactivity and socio-economic status. There's also a link between socio-economic status and poor health. Hope you're all with me still. Let's just have a look. Yep, okay, so don't forget, if you got any questions or chat. Okay, let's move on to our next slide. Oh, this is an interesting one. I thought I'd throw in just as an interesting thing. I was actually giving a talk on health inequalities at, I think it was LIW, and I was headed out on the Jubilee line, and it put me in mind of this. The Jubilee line of health inequality. So if you're travelling, you may have done this route yourself, you're travelling east from Westminster on the tube, on the Jubilee line. Each tube stop represents up to 1 year of male expectancy lost at birth. So as we move out, and you would say that, you know, some of the more expensive areas more centrally, but as we move out, for every tube stop we lose a year of life expectancy, and that's an often quoted the Jubilee line of health inequality. So you might want to look that one up yourself, but just an example of what we're alluding to here. Clustering of unhealthy behaviours, so a proportion of the English population that engages in 3 or 4 unhealthy behaviours, so that's going to be smoking, poor diet, excess alcohol, inactivity. So the proportion of the English population that engages in 3 or 4 unhealthy behaviours has declined significantly. That's interesting. From approximately 33% of the population in 2003 to 25% in 2008. So actually, despite all this ill health, obesity, etc., the number of people engaging in these unhealthy behaviours, having a smoke, having too much to drink, not being active enough, not eating well enough, the number of people doing that stuff has actually declined. Not just declined significantly. So if that's the case, you know, why are things seemingly getting worse? And that is mainly, the reason for this is because these changes are mainly among those in higher educational groups, and higher educational groups are linked to higher socioeconomic status. So people with no qualifications were more than 5 times as likely as those with higher education to engage in all 4 poor behaviours in 2008, compared with only 3 times as likely in 2003. So we've got some health inequalities going on here. There's lots of messages coming out from the government, change for life, etc. These positive messages around healthy eating and activity. And by and large, the higher socioeconomic groups within our society are responding to those messages, and yes, they are more active. They are eating more healthily. Maybe they've gone organic. They may have stopped smoking. They may be drinking less, but they're taking on board those messages. But it would appear that those in the lower socioeconomic groups are not. In fact, are headed in the opposite direction. Okay, so we can say that there is a social gradient in health. There is a social gradient in health. The lower a person's position in society, the worse their health. That appears to be the way it is, which, okay, you may have guessed that before you came in, but it is certainly a reality and something that as a society we need to address, both from a moral point of view, but also an economic point of view, also a National Health Service point of view. Just thought we'd put this in. I'm not very good with graphs, so if I confuse myself, I apologise, but hopefully you'll be more better. So let's see if I can explain it. So we can see that we've got age up the vertical axis, and on the horizontal axis we've got the most deprived on the left and least deprived on the right. And we can see that the first line is disease-free life expectancy. And we can see all those dots. They're all different neighbourhoods, and they all sort of spread out around that line. We've got a sort of trend line going through the middle there. And we can see that in the most deprived areas, the disease-free life expectancy, actually, they are the gap between that actually and the top line, which is their actual life expectancy, how long they live to, is actually wider there than it is at the top end with the least deprived. So basically, those most deprived areas are getting diseases, chronic non-communicable diseases. That may be diabetes, it may be cancer, it may be any number of things, maybe heart problems, earlier in life, and they're having to live with that for longer. Whereas in the least deprived areas, that gap isn't so great. So they're becoming ill later, and they're not having to live with ill health for so long. So that's the first thing that we can see. We can see that in terms of life expectancy, that those in the most deprived areas, again, at that top line, if we look at that, are actually not living as long, and we refer to, on average, 7 years less in terms of those deprived areas. So that graph, I guess, illustrates many of the points that we're trying to make here about the link between socioeconomic status, life expectancy, disease-free life expectancy. So I guess the fact that all the way through those two lines there is a big gap, again, is an indication of why there's such a strain on our health service, that by and large everybody is living, everybody is living with poor health for longer. We're living longer, but not in such great health. That's very taxing on our economy and on our health service. Okay, so the big society. Health inequalities arise because of inequalities in society and the conditions in which people are born, grow, live, work, and age. So we have health determinants, basically. Individual, we can see here all the things that would impact on a person's health. So individual lifestyle factors, health behavior patterns, so the things that we actually choose to do, the habits that we form. But also that health is affected by social factors and community networks, the communities that we actually live in, and how accessible healthy options are to us, whether that's being physically active, whether that's accessing good food, whether that's having an environment that lends itself to being active. And we can see that there's lots of other things as we move out in those health determinants, living and working conditions, so whether you're unemployed, levels of water and sanitation, health care services, access to all of these things. Education is a big factor that we'll see, you know, the higher education, how that impacts on your health. And we can see on the outer ring there general socio-economic, cultural and environmental conditions. So, you know, what is the condition of society we live in? Is it a time of austerity? Is there money around to fund various things? So I guess that slide is basically telling us that there are many determinants of health other than just the habits that we form, whether we choose to be active, whether we choose to eat well. Not all of us are living in situations that lend itself to following those active, healthy lifestyles. So we can see there, I think the pie chart in the right-hand corner is actually saying to us, well, you know, what things impact on our health, and we can actually see that healthcare is 15%, is a lesser proportion of how that impacts on our health, and often that's about dealing with somebody once they've got a condition rather than preventing poor health, isn't it? But health behaviour patterns have a 40% impact. But social circumstances and environmental exposure, the community that you live in, the environment that you live in, has the biggest impact of all. And I just pressed that button too quickly, but there we go, we're there now. So we have social gradients in health. In the UK, socioeconomic inequalities have increased since the 1960s, and this has led to wider inequalities in both child and adult obesity. So couldn't really talk about this stuff without talking about obesity, I guess. Deprivation and childhood obesity, and there's some sort of startling stuff here. So we've got the least deprived on the left, we've got obesity up the vertical column there, and most deprived on the right-hand side of the graph. And immediately we can see, so reception, when they first go into reception, you may have kids in this situation yourself, mine are long out of this situation. When they first go in, we can see that in the least deprived situation, we have less, 5.9% obesity. In the most deprived situation, we have 11.9%, virtually double the levels of obesity, just going into reception before they even really started school. So one of the things we've got to ask ourselves here is, you know, is anybody out there impacting on kids before they actually come to school? You know, the under fives or whatever. I was talking to somebody at a conference, a lady at a conference, who's actually set up a business around that whole area and is drawing down lots of funding, etc., around working with preschool children, because clearly those habits are established very, very early on. I would say as well that UK Active and most of the papers that come out around this area about getting people active, CMO, Chief Medical Officer guidelines, they talk about, there's a paper out, and I'm just trying to remember the title of it. Stay active. Maybe I can get that for you guys. But CMO guidelines talk about a life course approach. So, you know, if we're going to impact on the levels of inactivity and poor health out there, we need to look right across the life course. And they actually refer to, you know, impacting on the unborn child in the womb through, you know, healthy impact on the mother, etc. So we have to take a life course approach. But it is worrying that we have these levels of obesity actually coming into reception. And then we can see that at year 6, so this is now them coming out of primary school, I guess, what then happens, and this is even more cringe-worthy actually, isn't it? This is horrible, yes, okay, again we can see in the least deprived areas there's less obesity, 11.7%, 24.3% in the more deprived areas, so the more deprived, the more obese. But the scary thing of all is that in all of those cases, they go into school with a level of obesity, and by the time they've come out, in most cases, they're almost twice as obese. So we've got to ask ourselves, what the hell is happening in those situations, in that primary school education, that is leading to that? Well, you know, what's happening in the school? What support is there for, you know, healthy lifestyle approaches? And that may well, and there are many people trying to impact on that area in terms of, that may well represent an opportunity there. But I would suggest that setting kids up at this stage with those levels of obesity and not encouraging them to change is a recipe for disaster in terms of our society in the longer term. So, just thinking about my kids then when they went into school and what they did, and you may sort of think about the same sort of stuff. Obesity figures, and I just threw these in because they're a bit scary. 1993, 30% of men, 16% of women are obese. 2011, 24% of men, 26% of women obese, up to 48% of men and 43% of women in the UK could be obese by 2030, and that's from the Lancet. So again, what are we doing, guys? How are we impacting on this situation? How can we impact on this situation? 12.6% of the population coming to our gyms, okay. We're making a bit of money there. The gyms are making a bit of money. Personal trainers out there, I'm sure, are making good money in many situations. But we're living in an increasingly obese society. Right. How are we doing for time? 13:27. So a bit to go yet. Hopefully I'll have time for a few questions, and there will be a few questions. But education. I've mentioned education already. So more education reduces the risk of self-reported poor health. Yeah. So education is linked to health status. £1 invested in education returns £2.25 to £7.20 in value of additional health gain. So the more educated our society, the healthier it's going to be, the better choices they're going to make. You know, there is some link there with socioeconomic status, but I think that's a really interesting fact, and I guess something that we all need to consider. Time spent on education is never wasted, not just in terms of career, but also in terms of health. Education for life. So what have we got here? Another graph to get my head around. Again, this is linking to obesity prevalence. So those we've got men and women, green and reddish. So no qualification, and we can see that the levels of obesity in that situation are much higher. And then as we move up the ladder in terms of educational achievement, clearly, you know, these are trends. These are not the case in every individual case, but these are trends at degree level. Then those levels of obesity come down. So education for life, that's something that we need to consider. Something the government certainly needs to consider. And education gets us more active, and being active is linked to better educational achievement. So it's a very positive circle there, isn't it? Okay. So who to blame? Eh? That's interesting. People from more deprived areas tend to make poorer health choices. So we've talked about the clustering of health behaviours. So yes, those people in those poorer communities, they tend to engage in more than one unhealthy behaviour. They may be drinking, they may be smoking, they may be inactive, they may be eating poorly. But you know, how does their community, how does their situation in terms of the money that they have to spend, the environment that they're living in, how safe they feel to go out and exercise, access to gyms, they may not be able to afford that, etc. Should we blame individuals or families within these groups? Do they, you know, is there some, they need to take some personal responsibility here, or you know, are they helpless in this situation? What can they do for themselves? The whole infrastructure that makes these choices more likely and healthy life choices disproportionately more difficult within deprived areas and for people on low incomes. Yeah. So in many situations, while you know there are some individually poor decisions being made, the infrastructure, the environment these guys are faced with doesn't lend itself to this, to many healthy lifestyle choices or the ability to access a healthy life. So tackling health inequalities is a matter of social justice with real economic benefits and savings. So for the government, there's an awful lot of money now floating around, being pushed towards getting people to engage in active, healthy lifestyles. And certainly there is an increasing recognition at government level, and certainly within public health, in the public health situation, that physical activity is a key part of the strategy of getting a healthier society and tackling some of these health inequalities. So public health, I'll talk about this now, I think we've got slides on it later, but public health basically in the Health and Social Care Act in 2012, the public health went over to the local authorities, and they were given 5.2 from the health service studies, and they were given 5.2 billion pounds to actually try to impact on public health. A lot of that money, unfortunately, gets spent in other areas like dealing with areas such as sexual health, and there's a lot of money gets spent on areas such as other public health areas, and there's been a lack of recognition of the value of physical activity up until this point. But Public Health England are now very much committed to the physical activity piece and to funding programs of physical activity that will impact on some of the poor health that we have in our society, and that will particularly impact on some of these health inequalities. Anything that is focused on the more deprived, socioeconomically deprived groups in our society is likely to get their attention, or likely to, disproportionately get their attention. There's something called proportional universalism, and proportional universalism is trying to help everybody. You know, it's a universal approach, but it is proportionately weighted towards those most in need, and in this situation, those from the poor and more deprived sections of our communities. So there is a recognition of the value of physical activity, and if you want to go online, Public Health England, they have loads of papers, Everybody Active Every Day, which is all about the benefits of physical activity, and Public Health England saying that, and that they need to create an active society. If you want to go on and have a look for the NHS 5-year forward view, they put a tremendous emphasis where they haven't previously on prevention of ill health, and a big part of that is around the physical activity piece as well. So increasing government recognition of the value of physical activity. Just to read this out, it is estimated that inequality in illness accounts for productivity losses of 31 to 33 billion per year. So it's not a completely selfless thing that the government are doing this. They're doing this because economically affecting the nation's health in a positive way makes sense. So just talked about this to a degree. Health and Social Care Act 2012 placed specific legal requirements on the Secretary of Health, NHS England, and the CCG's clinical commissioning groups, that is, to reduce health inequalities. In exercising functions in relation to the health service, the Secretary of State must have regard to the need to reduce inequalities between the people of England with respect to the benefits that they can obtain from their health service. So again, this idea of proportional universalism, that we have to try and impact more in these areas where there's greater need. A common aim, Health and Social Care Act mentioned that, responsibility for public health with local authorities now. So, yes, it was with the health service, responsibility for public health got passed to local authorities, so a much more local approach now. Now, you know, I've gone around the country, been working with a lot of leisure trusts who take on public leisure service contracts, and they therefore have a direct link with the local authority who have a link, with public health sitting within those local authorities. So those leisure trusts are starting to draw down funds around developing various physical activity programs, various programs that engage with their communities. So we've got a much more localized approach now. And certainly, you know, I've gone in and delivered within those leisure trusts, drawing down public funds to deliver training that will support some of these programs. We've got clinical commissioning groups now and health and wellbeing boards. I won't go into that too much, but in terms of health service funding, well, public health have got 5.2 billion. The health service itself have got 65 billion. to spend, and that is now being, instead of being run by primary care trusts, PCTs, is now being run by groups of GPs who come together in clinical commissioning groups. Now, I'm starting myself, I believe, to have an impact in the public health environment with public health authorities. It is still more difficult for me to impact with those health service providers, with GPs. They're notoriously hard to reach, but I think we're starting to make some progress. Those GPs in their clinical commissioning groups come together with public health and the local authorities in what are called health and well-being boards. So that's a meeting place for all of those people. So if we can start to get the right messages into one of those groups, it will affect the whole piece. You will have a local health and well-being board in your area. Go on there, have a look at it, look at the areas that they're focusing on. What are the issues in your community? You know, are there issues around levels of unemployment? You know, what are the major goals of your area in terms of affecting the health and well-being of your particular community? If you look up health and well-being boards, it will tell you a lot. You should also look up your local JSNA, which is your Joint Strategic Needs Assessment. I forgot that there for a second, but it came back to me, thank goodness. Your Joint Strategic Needs Assessment, and that again will lay out the health priorities in your particular community, in your particular area, and it may be that you can offer a service that would actually support that JSNA. It may be that you should be going and talking to your local authority and to your public health people within that as regards some of the services that you could potentially offer. There's so many things happening in communities now. You know, people running outdoor activities. I go down my local park and I see people in the park doing sessions, and it's fantastic. I love it. There's health walks. There's lots of stuff around cycling. So there's lots of stuff happening out there now that potentially or previously wasn't there. And there's a much greater awareness, I think, across our society of the value of these things. Loads of opportunity. Collaboration and integration. The health and fitness sector should engage in a collaborative approach with the health sector to develop inclusive, localized programs that support the whole community, but offer disproportionately, this is a disproportionate universalism, but offer disproportionately greater access to those less well off. Just as an example, because I've got a few more slides, but I'll run out of time if I don't wrap things up reasonably soon. But I want to give you an example of some of the things that I've personally been doing in terms of trying to get out there and make a difference. And one of the things I'm currently doing as an example of that is I'm working with Somerset County Council and the public health team within that council. So they basically, they have public health money. Remember I talked about that 5.2 billion. And we have developed at Premier a certificate in promoting community health and well-being, which is all around this area of health inequalities. It's around promoting active, healthy lifestyles through using behavioural management, for example. Motivation and interviewing techniques are central to that. But how to, let's face it, a lot of the guys that aren't engaging at the moment are difficult to get to. So those behavioural management techniques are going to be vital in that. So there's a big aspect of of behavioural management. Also a big aspect in terms of how to get out into your communities, interact with that community, find out relevant information about activity levels, etc. within the community. So we have that course. What we're doing in Somerset is they're funding us to go in, and we've delivered the course now in Somerset. They've advertised it to their community, and within their community we had 20 odd people coming from a whole range of people. There were leaders of health walks there were youth workers there were personal trainers there, there were swimming pool attendants, there were people working who take groups of people out into the forest to discover the wonders of the forest. There were emotional outreach workers there, but basically there were people from faith groups there. There were basically a good cross-section, an excellent cross-section of the community, and they get They come in, public health pays for them to receive our training, and then they go back out into the communities as health and well-being practitioners, as we call them. You might call them health champions, but they go out and they try to positively impact on the sections of the community. And if they can positively, disproportionately impact on those in greatest need, then all the better. And we're tracking their progress, the number of interventions they have, how they signposted to various other services, etc. So that's an example of how our sector is just starting to work with the health sector, with public health. You know, can we actually get to those GPs and start to work with them? This is what I'm all focused on. It's really my working day these days, is thinking about how I can do all this stuff. But that's an example of where we're making great strides. If we can show real outcomes there, and that's a big part of it, if we can show some real impact, then I would hope that we will continue to get other public health contracts. Okay, I think what I'll do, I'll just quickly, because I want to finish at 1:45. We've got 3 minutes left, and then we'll see if there are any questions out there. We'll see if we can answer them. Okay. Yeah, I just wanted to maybe refer as well. You know, I'm thinking of you guys out there, maybe personal trainers, gym instructors, and how this will impact on you. Well, it may well, if you're working in a gym situation, it may be that you find that this increasingly impacts on you, in that you know, if you're working with a leisure trust, etc., that they are increasingly putting on programs that interact, that are based out into the community, are quite innovative in that sense, and you may be required to go and do that sort of stuff, to lead some outdoor activity, to work with sections of the community that are more deprived, to lead health walks, whatever that may be. And it may be that you would, in doing that, you would be better informed if you had some greater training around behavioural management. This is a huge part of what's happening in our industry at the moment. That there's a feeling, I guess, that while there are a lot of technical skills out there, do people necessarily have those soft skills that they need to engage with those sections of the community that don't necessarily want to engage? So that's a big focus for Premier Training International. It's something that we're addressing within our diploma, and we're addressing more widely with qualifications like the community and promoting community health and well-being qualification. That we want to give people those behavioural management skills, how to talk to people in an empathetic way, how to support them without being overly directive in your approach. So behavioural management is a huge part of what we're doing there. And I guess, you know, as the R&D director, I can see that perhaps that has been overlooked to some degree, but something that we need to address. I would also say that it's an interesting environment because there's new things springing up all the time. We're working with another organisation called Live Well Suffolk. Live Well Suffolk are a commercial provider, so they are actually providing health and wellbeing services. They are drawing down public health funds through public health authorities to deliver programs. That might be around activity, it might be around smoking cessation, it could be something around alcohol awareness, but these are commercial companies that are not health and fitness companies. They're employing health and well-being managers, health and well-being champions, they are smoking cessation experts, lifestyle service providers, if you like, and they're delivering on these public health contracts. Now, clearly, they are looking for employees to work within their situation. So I'm thinking that there's a whole nother market, there's a whole nother potential for graduates coming through Premier that, yes, you can look into the personal training business, but if your bent is more health and well-being, if you're more that sort of exercise referral person than you are that throwing kettlebells around kind of person, that there are opportunities outside of health and fitness now with some of these commercial providers in terms of health and well-being. my job is to identify what those roles are and to put them in front of you guys, but also to provide training to you guys so that you can capitalize on those opportunities as they increasingly arise, and they will. There will be an increase in these sort of roles. I'm waffling now, so my apologies. It's quite difficult to talk when you don't get any necessarily any comeback. So I feel like I've exhausted myself there, and hopefully I haven't. Hopefully there's been some level of interest. So if you have any questions, I'm just trying to just have a look. Oh, hello. My little helper is just coming in now, just to make sure that I don't press the wrong button. So, how do I, let's expand that. Bear with me, guys. I think if I do that, there we go. I think, oh, hold on. Yeah, all work. Let's just scroll down, guys, because I think, we've got some questions, so let me see if I can answer them. First of all, we've got a question here. Is it Vidya? So my apologies. What is DFLE? That's disease-free life expectancy. So if you think of that graph, you know, how long are people living in good health before they actually have some recognizable diagnosed condition? You know, what we're generally referring to there is a non-communicable disease, as it would be described. Yeah, it might be a heart condition, might be any number of chronic health conditions. So disease-free life expectancy. Shocking stats. We need to target mums and dads. Yes. Well, yes, we do. You know, and we need to, rather than, I'd like to broaden that and say families. Really, the family is a key unit, and if we can impact on that and the messages that they give to their kids, then you know, hey, I'm always amazed how my kids seem to just replicate what I've done in my life, and that because they look to their parents, don't they? But in some situations, that's not always a good thing. They must provide healthy role models and feed kids good food. Yep, again, I couldn't agree more. There are many schemes out there now that are drawing down public health funds that very much focus on that, focus on the family. I mean, obviously, from a central government point of view, Change for Life, these kind of initiatives. We need to get into the schools to impact on the kids. Don't remember the primary school stuff, that they're going in obese and coming out even more obese. We need to be giving those kids the right messages so they'll actually take those messages home to their parents as well. It works both ways. In my opinion, there is a lot of inactivity in youngsters compared to what they would be doing without so much indoor. Yeah, absolutely. How do we counteract that indoor entertainment? There's a slogan now that's about that. I keep hearing that sitting is the new smoking. That, you know, sitting around is you know, actively unhealthy. That even, let me put it like this, I go to the gym a lot. I love the gym, always have. But I might go and do that. But if I'm not active the rest of the time in my normal daily pursuits, then I can soon offset all of that good work in the gym. We need to be active at other times. And you know, just standing, they're talking about standing environments in offices now. Because you know, that increases our metabolism. So sitting is positively bad for our health. Due to environmental factors, e.g. not enough exposure by educated parents, so the parents things again, okay, I couldn't agree more. Surely more education to the parents through schools is the way forward. Absolutely, you know, involvement, get those parents into the school, get the kids going home to their parents with the right messages. You know, again, I know of a scheme of work with South Suffolk Leisure there. They've got a program at the moment, Jump back into employment. So they're working with unemployed people. They're getting those unemployed people to come in and have behavioural management sessions to encourage them to be more active, and giving them also guidance in terms of getting back into work. But they're also having sessions where they're bringing those unemployed people in with their families so they can talk to them as a family, and that would, that would sort of answer some of that. And that's from John there, John Clutterbuck. And yes, shocking stats, Jenny. Yeah, I would agree. And there's many more shocking stats. Like I've got a list here I could read you, which would, yeah, it's pretty scary stuff. In my opinion, hi Catherine, here I'm a PT, but also a network business. The company is, here in the UK, we are starting group workouts to bring people out to start exercise, walk, run, cycle. This runs well in hand with being a PT. You're welcome to contact me. Thank you, Catherine. I will bear that in mind. I'd love to contact you, see what you're doing. But hey, I mean, that's what it's about, isn't it? Getting out into communities, not sitting behind the walls of a facility waiting for people to come to us. Get out there. There's massive opportunities in terms of accessing people who don't necessarily want to go to the gym-based situation. We've got an increasingly elderly population. What the hell are we doing with all those guys? How many walking groups of elderly people, do we see? I don't see that many. It is happening. There are groups out there, Nordic walking, that are doing that kind of stuff. But to me, as a market niche, that over 60s population, and not necessarily in a gym-based situation, is a massive market. Stability training. We can talk about the Otago program, which enhances stability, postural stability. Fantastic stuff. I'm with you. Good. Oh yes. Following this. I'm looking to take this on. No, right, Catherine, you're finding some people to help you. Hopefully, what's the best way to be able to find more information on where most deprived areas are, Daniel? Well, look, I can send out some stuff. I got loads of reports. There was a report by UK Active, which Daniel actually identified those areas and where they are. And I did actually. I forget which was the most inactive, the most active, the most deprived, the least deprived. But I can get that information, and we can maybe forward that on to all of you guys. Do Premier plan to do a qualification, of course, regarding these issues? Yeah. Well, Rebecca, I guess that's our promoting community health and well-being. That's a level 2 qualification at the moment. But I'm all about pathways, and we will be developing other courses around this whole area. Certainly in terms of behavioural management, because that can get quite technical, and there's lots of skills to be taken on board there. Clearly, there's links here with exercise referral and with the level 4 stuff as well. But at the moment, we're focused on the level 2 community health and well-being, because we're trying to get as many people from our industry and outside it with an increased awareness of this area as we possibly can. Used to be youth work on obtaining change for life materials via DOH is impossible. Okay, had to go to local contact to get materials for proliferation. Government is failing at last. They need us. Absolutely, they need us. But I had this conversation with one of the training team just yesterday, that they do need us, but there's an issue here, and the issue is that often they see the personal training, health and fitness industry as a gang of lycra-clad, well-muscled individuals, and the gym situation as a very intimidating and inaccessible one for many people. So as soon as if I'm in those sort of circles, public health kind of circles, and I start talking about personal training, I can see the shutters go down almost immediately. We have to. It's almost like we need a rebranding here. This is, we're about physical activity. UK Active are big on this. They're doing a great job in that they're very focused on the physical activity agenda. But broaden out what you do. Personal training. Okay, great. It's a wonderful thing. But also, if we're going to reach those other groups, then you're a physical activity specialist. You can help any number of people, and it's not just about, clearly there's a marketplace for people who want to get great physiques, and I'm all into all of that kind of stuff, but from a general health perspective, when I first came into this industry more than 20 years ago, it was, we were talking about, well, wellness. Over in the States they talk about wellness, and finally that's sort of happening. We are genetically coded to adapt to climbing trees. I wouldn't disagree. Yeah, let's climb a few trees. I used to climb trees as a youngster. I was good at it too. I was proud of my tree climbing ability. Great stuff. What can we do a course for us to instruct under 5s? There is a course actually on older children, and I'm looking at that area. Under 5s, there's an active IQ course, off-qual accredited course that we could teach in under 5s. is doing it all. But yes, thank you for that. And older children, yeah. There is an adolescence course as well, active IQ. I guess, it's, yes, Rebecca, food for thought for me. To enable us to do all of these great things, we need to see to be seen as a professional and respected as an industry, especially from public health. Yes, absolutely, Shelley. Totally, we do. One of the big issues at the moment is that they all recognise that exercise works and physical activity works. It makes us healthier. It offsets various chronic diseases. It's, there's no argument about that. But they still, half the time, they don't fund it. And one of the reasons for this is that although we can say that, yes, it works, and yes, we can say that that people will initially take it on, what there isn't evidence of, where the evidence is lacking, is in terms of adherence. So exercise referral recently got a very bad press from NICE. They basically don't recommend exercise referral schemes as something that work, because although exercise works, people don't stick with the programs, so they don't make those long-term gains. And even if they are sticking with the programs, and I'm sure there are schemes out there who have achieved fantastic results, even if they have achieved those results, have they documented them? This is where and Nuclear Active again are huge on this. We need to show evidence as an industry that exercise, that the programs that we administer, that we deliver, have had an impact, that we can show meaningful health outcomes. That may be BMI, it may be in terms of blood pressure, maybe lots of different things, maybe in terms of a more positive mental state, whatever. But we're currently, as an industry, not evidencing what we do and not evidencing that long-term benefit of physical activity. We're back on the trees again, John. Get to the trees, climbing frame, and get kids. I could stay here all day and talk about this stuff. Interacting physically with the outside world, they naturally love it. My little girl, she's just finally mastered the monkey bars, and I see all these girls down there, little girl, be careful, doing the monkey bars, and it's fantastic. They can support their own body weight. They're brilliant at it, absolutely brilliant at it. And I'm wondering, as they get older, how many of them lose that ability and lose it quite quickly? But yeah, let's get out there and interact with our environment. Brilliant. And maybe just be walking, and there's lots of stuff going on there. One major issue in tackling child obesity is bridging gap between rich and poor. However, funding is being cut for community projects, so is the deprived that missed out. Yeah, catch-22. Yes, I guess it is. The funding is being cut, and people are having to be increasingly resourceful in the schemes that they come up with. Although I guess I'd refer back there, Helen, to that disproportionate universalism. That's it, isn't it? In that the funding that is out there is, in many cases, focused on those groups, on those more deprived groups, and that's something that we need to do. We also need to stop selling activity as something we have to buy or find time for. We need to start promoting the benefits, the positive outcomes, and start delivering the message to pregnant mothers and all the way through the life cycles. Yes, Shelley, that's back to that life course approach. Couldn't agree more. I used to teach the pre and postnatal course here for Premier, and I managed to keep my partner exercising through her pregnancy. It's great stuff, fantastic, love it all. Yeah, we need to stop selling activity. That's interesting. I'm just actually in the course now of writing some new content for our diploma course around the whole PT side of things and selling PT. As soon as you use that word selling, everybody turns off, right? And everybody associates it with that whole hard calling kind of approach, hard sell kind of approach. But actually, what selling is fundamentally is connecting, isn't it? It's connecting with people, and whether that's in the gym or whether that's outside the gym, the more connections that you can make, the better you're going to do. Whether that's selling PT down the road or whether that's just encouraging people to be active. Get out into your communities, connect. Yes, take the emphasis off selling. That's not what we're about. This isn't something that should be sold, but if you can connect and get people's interest, then perhaps you'll have more impact. So yeah, maybe move from selling to connecting. Think about that mindset. Interesting facts. I've organised a health and fitness show, which is free for local people to come along to in Spalding. Brilliant. Lincolnshire on March 28th to promote ways of getting fit and active. I'd be grateful if you could give this a mention. Zoe. Yes, Zoe. Fitness show. Zoe, health and fitness show in Spalding, Lincolnshire. 28th of March. Brilliant. That's the sort of thing, you know, to promote ways to get fit and active. Why the hell not? That's how you're going to impact on your community. You're getting out there. Okay, you know, there's not an immediate monetary return, but you're raising your profile as that person who's out there to help people, to improve their lives. IMO, there is too much of a sense of pressure to keep active. Reminding people of joy with exercise, dance, sport for joy needs to be remembered. Yeah, even by the elderly, certainly. Rebrand PTs, wellness coaches. Guys, we're almost at the end there, but I think we've sort of hit 2 o'clock. Hopefully I've mentioned most of your questions. People are talking there about Chinese health exercises, mind and body, fantastic. Tai Chi kind of stuff, I guess. Brilliant, love it, very good. Elderly stuff, my dad did his Tai Chi rigorously every morning, not rigorously, you know what I mean. Thanks so much. Oh, thank you, Helen, that's very nice of you. Thanks, Catherine, too. Okay, well, I'm going to stop it now. Which takes us back to the skills needed to communicate and connect that currently are lacking in qualifications. I agree, and in many ways that's my oversight. You know, we haven't done that well enough, or put that message across strongly enough. I'm working on it.